So good afternoon, everyone, and thank you for joining us for the Overdose Prevention Engagement Network webinar. Welcome to today's session, Buprenorphine in Primary Care, Key Considerations for Pain Management. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBAP credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. My name is Katrina Hernandez, and I am an engagement specialist with OPEN, the Overdose Prevention Engagement Network, and I will be moderating the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBAP credits, and for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants, and we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machine and distribution boxes and offer naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually as a group, have relevant financial relationships with ineligible companies. And now to introduce today's speaker, Dr. Jane Chargot is board certified in family medicine and hospice in palliative care. She practices both full spectrum primary care and palliative care with a prior background in critical care nursing. She's a clinical assistant professor at the University of Michigan Medical School. She's the founding and lead faculty for the General Palliative Care Clinic, one of the 3 main palliative care outpatient clinics, and attends on the inpatient palliative care service. Her research interests include translating cutting-edge advances in palliative care into meaningful patient outcomes and the intersection of palliative care and primary care, as well as medical education. Her clinical work also focuses on the intersection of palliative care and primary care, specifically on management of patients with complex chronic disease. Within this population, she has a special interest in facilitating the transition of pediatric patients with complex disease burden to adult care. And with that, I will turn it over to you, Dr. Chargot.
Well, thank you all for joining us today. I'm really excited to be presenting to all of you. Just start off with disclosures. I have nothing to disclose. A quick outline of what we will be talking about today. We're going to be reviewing buprenorphine's mechanism of action. We're going to be reviewing three different cases. The first one will be more representative of the evidence for buprenorphine in pain management. The second one focusing more on using buprenorphine as a first line for pain management for opioids. And the third one, the crossroads of pain management and substance use disorder management. So to start off with, buprenorphine's mechanism of action. Before I get started, just a few thoughts. A reminder that buprenorphine is an opioid. I feel that there's almost an impression out there that this is almost felt to be a magical medication. This is an opioid with opioid-related side effects. However, in comparison to a full agonist opioid, things like morphine, oxycodone, dilaudid, fentanyl, this has a reduced risk profile. Because of this, for those patients who are opioid appropriate, consideration of buprenorphine is an option for pain management that's gradually becoming more the standard of care. This is going to be a quick review of the various receptors that buprenorphine affects. We're going to go into each one more in depth in the following slides. But briefly, the primary pain management action is due to the mu opioid pain receptor, this one right up here, very similar to typical opioids. However, buprenorphine also works as a kappa opioid receptor antagonist, a delta opioid receptor antagonist, and an ORL1 or NOP receptor agonist. So why do we call buprenorphine a partial agonist opioid? Opioids all work on the mu opioid receptor. With the full agonist opioids, the higher the dose, the more activation of these receptors, increasing the pain and analgesia response as well as the respiratory suppression response. Partial agonist terminology for buprenorphine is really referring to the respiratory effect of the buprenorphine on this receptor. It has nothing to do with the pain effects. Buprenorphine has a threshold respiratory effect, meaning that past a certain dose, there really is no further respiratory suppression. Why is this? We think that one of the main active metabolites for buprenorphine's mechanism of action doesn't really efficiently cross the blood-brain barrier. And because of that, it's producing mainly its effects peripherally rather than centrally. And because centrally is where the respiratory suppression really comes from, it's reducing the respiratory side effects. I really love this particular graph because it helps my own visual brain really grasp the comparison. So this is a rat study that has been borne out in further human studies. On the left, right here, this is fentanyl. Basically, what this is showing is that the higher the dose, the more suppressed our respiratory drive is until zero and potential death. The one over here on the right, this is buprenorphine. And again, the higher the dose, it initially does have a respiratory drive suppression up to a threshold of about 10 or 9 breaths per minute. And it really means that it's unlikely to cause an unintentional fatality if it was unintentionally overdosed. Um, this is really something to remember that if we use this in combination with other full agonist opioid therapies, with benzodiazepines, other medications that could compound respiratory suppression, this raises that risk back up again, and that it's a little less potentially beneficial. But on its own is a big risk mitigator in comparison to a typical full agonist opioid. This slide is from my colleague, Dr. Kyle Quirk, but very similar slides can be found in a lot of different places. I really, again, love this slide because it visually helps me summarize the reason behind the changes in buprenorphine functionality as the dose increases. So pain management, analgesia down here, is really achieved when the new opioid receptor occupancy starts as low as 5%, which we start to get 15 to 30% mu opioid receptor agonist, our opioid receptor occupancy when we're at 1 milligram. What this means is that we have pain benefits with buprenorphine when we're in the microgram range of doses. This is a really much lower occupancy requirement than for full agonist opioids, meaning it's much more potent and it's aiding in its effectiveness for pain management. And the potency is really due to the strength of its bond to the mu opioid receptor, which is exceptionally strong. And as you increase the dose, you occupy more and more of these receptors, and you gain more secondary benefits. So down here, as you see, we start to inhibit craving around 50%. We're reliably occupying about 50%, somewhere between 2 and 6 milligrams of buprenorphine in a day. Then around 80%, we start to block subjective effects of misused opioids. Again, we start to really reliably get this opioid receptor occupancy around 16 milligrams. When it comes to practical pain management, in our practice, we don't go past 12 milligrams in a total daily dose for pain management. Our reason is that while there's evidence of increased pain benefit, we're losing the ability to use a full agonist opioid for breakthrough pain management at doses higher than 12 milligrams in a day. And that'll block those full agonist opioid effects. And for many patients, this might still be a desirable ability. In my practice, particularly in palliative care, that's something that we would want to be able to do. The kappa opioid receptor, the buprenorphine, antagonizes this receptor, which then indirectly antagonizes the NMDA receptor. This downregulates the body's pain response, decreases opioid-induced hyperalgesia, decreases tolerance associated with chronic opioids. The NMDA action also results in decreased dopamine release from the nucleus accumbens. That decreases in turn the risk for addiction and abuse potential. NMDA also has benefits for neuropathic pain and decreased pain centralization. It's not as strong as some of the other benefits for this particular medication, but it does have a moderate neuropathic pain benefit. This is the next receptor is the delta opioid receptor. Buprenorphine is a weak antagonist here. And the delta receptors are more found prominently in the peripheral nervous system rather than the central nervous system. And it seems to have a gut predominance. So when we're antagonizing or not activating this particular opioid receptor, it then reduces the constipation side effects in comparison to a full agonist opioid. It also can help mitigate tolerance and opioid-induced hyperalgesia. ORL1 or NOP agonist. This is a somewhat unclear mechanism, and we believe that it helps reduce opioid-induced hyperalgesia and tolerance development. And we also believe it helps reduce that dopamine release, and again, is beneficial for addiction risk mitigation. So just to recap, buprenorphine mechanism of action highlights. On its own, it does not cause respiratory suppression sufficient to cause death. It has less hyperalgesia and tolerance. It has less constipation. It has decreased addiction potential. It may help decrease centralization of pain. And it has a mild to moderate neuropathic pain benefit, all in comparison to typical full agonist opioid. So our first case is demonstrating the evidence for buprenorphine in pain management. So this is Miss ST. She's a 70-year-old female patient of mine. She has a complex past medical history, including alcohol use disorder, coronary artery disease. She's had multiple cardiac valve surgeries and replacements, and she has heart failure and COPD. She has chronic back pain related to musculoskeletal pain, along with radiculopathy or sciatica. And she has severe peripheral arterial claudication with ambulation, which is thus limiting her function. Related to her valve replacements and peripheral arterial disease, she's on systemic anticoagulation. She cannot take NSAIDs, and acetaminophen has really not been very helpful for her pain management. She's already on an SNRI, which has not been very helpful for her pain management, but does help with her depression. And gabapentin has been somewhat helpful for her low back pain and sleep, and we do have that, but she has not tolerated it during the daytime. She's been on Norco, which is hydrocodone with acetaminophen, 7.5 milligrams with 325 milligrams of acetaminophen, 1 tab 3 times a day for years. It's been helpful, but there's a lot of ups and downs in her pain and is progressively more limiting to her function. Her current pain, when it's at its worst, is between 7 to 9 out of 10. She's rated as severe. Her current opioid regimen, as we talked about, is 7.5 milligrams of hydrocodone 3 times a day. She takes typically 3 times a day, doesn't miss any doses. And this typically brings her pain down to 5 for about 2 hours. Her goal is to improve her pain management to optimize her functional status and quality of life. Further considerations for her, she has COPD, so increasing respiratory failure risk. She has neuropathic pain, but still hasn't been adequately managed by both her gabapentinoids or her SNRI. And she has a history of substance use disorder, mainly alcohol, and this is currently in remission. So, what is the evidence out there for buprenorphine and chronic pain management? The first one that I really like to point out is this meta-analysis that was published in Springer Plus back in 2014. And it really demonstrated that buprenorphine was, 1, better than placebo, and 2, either superior or non-inferior to the controlled comparison opioid. The next study is a systemic review that was published in the journal Drugs in 2018. This one demonstrated that chronic pain, and I would lump cancer pain within chronic pain, buprenorphine had less side effects, less drug interactions, and was non-inferior for pain relief when it was compared to controlled opioids. And this last one was an open label clinical trial that was published in the Journal of Pain and Symptom Management in 2006. And this one was done in Europe. It worked with end-of-life patients who were enrolled in hospice. This one I wanted to point out because I think a lot of people have a sense that we can't use a full agonist opioid with buprenorphine because its effects would be blocked. In this population, we used low dose buprenorphine, so essentially 2 milligrams total daily dose or less, and that they were able to use a typical full agonist opioid, so like morphine or oxycodone, at typical doses for breakthrough pain, and there was no impairment in its efficacy. There was no reduction in its efficacy, and they were able to use this for breakthrough pain management easily. So essentially, with low dose buprenorphine, there is no trouble using something like morphine or oxycodone at usual doses for breakthrough pain. So what are some of the factors that I think about when I'm considering buprenorphine for pain management? The first thing is prognosis. If somebody has a longer prognosis, thinking months, years, and they have stable pain, we really want to think about making sure that the medicines that we're giving them isn't promoting those things like tolerance or hyperalgesia. So I do typically think about buprenorphine in this population. In a population that has a high risk for rapidly changing symptoms, somebody who's acutely dying, somebody who is in a post-surgical, somebody who has disease that's rapidly changing, it may be less beneficial to think about this medicine until after they've stabilized with their pain. So some other risk factors that I think about, so liver or renal failure, I really think about buprenorphine with these patients because it is not metabolized or eliminated either in the kidneys or the liver very predominantly. It's essentially 80% eliminated in the gut. It's not dialyzed out. We don't have to dose reduce even for end organ failure. When somebody has something like dysphagia or inability to take oral medications, I really start to think about this because it's not a pill. It's either a tablet under the tongue, a film in the cheek, or a patch. When somebody has high risk for respiratory compromise, again, buprenorphine alone doesn't suppress to the point of potential death the respiratory drive. So this would be a safer medicine for them. In a patient with gastroparesis, We would prefer this medication in comparison to a full agonist opioid, as it's less constipating and would have less impact on gastroparesis. Still could aggravate your gastroparesis, but have less bad consequences. And polypharmacy, it has a ton of opioids have a ton of interactions with other medications. So for example, many full agonist opioids have serotonergic effects, and they can precipitate serotonin syndrome in patients who have other serotonergic medications, things we have to think about. For buprenorphine, it does not have serotonergic effects to that extent, and it has a lot less interactions in comparison to full agonist opioids in general, and more. So things that might make me think not to use buprenorphine: if a patient has severe mucositis, radiation changes within their oral mucosa, if they have dry mouth, that might mean that this might not be a great patient to use either the sublingual tabs or the buccal films. If they have a history of adhesive dermatitis, that also might limit buprenorphine use via the patch. So buprenorphine dosing. The first thing that you want to do is calculate how much opioid the patient is already on at baseline and convert to something called oral morphine equivalents. And I will have a conversion chart at the end of this presentation for you to reference if you need to. The next thing that you need to consider, so for our patient, just to go back, she had 7.5 milligrams 3 times a day. That comes out to roughly 24 oral morphine equivalents in 24 hours. So the next thing that you want to think about is the route. So if a person has less than 100 oral morphine equivalents in a day, you are considering probably what we call low dose buprenorphine, or buprenorphine that's dosed in microgram ranges rather than milligram ranges. That means that your options are typically usually the patch called the Butrans patch, or low dose buccal films, which are called Belbuca. So how do I make this decision? I start to think about whether or not this patient might have an adhesive allergy. Do they have dry mouth or oral mucosal sores? Do they have an ability to be able to manage a multi-day regimen? So for this case, we're really going to consider the patch. This is a really easy medicine for patients to manage. The patch lasts 7 days. It delivers the medication evenly throughout that week. And so once you have that patient's opioid requirements, you can then refer to dosing recommendations for the patch to choose which patch dose to choose. This data that I lifted was directly from the database LexiDrugs, but there's a lot of different places that you can find it, including on the medication website. So if your patient is opioid naive, or if their total daily dose TDD is less than 30 oral morphine equivalents, which is our patient, you would start on 5 micrograms an hour. If you're between 30 and 80 oral morphine equivalents in a day, you would start at 10 micrograms an hour. If you're between 80 and 100, you would start at 20. If you're over 100 oral morphine equivalents in a day, the patch is probably not the right choice for this patient. Just for your awareness, there is a black box warning on buprenorphine for QT prolongation. This is still flagged in the US, but it's really not pertinent to us overall. The QT prolongation is only if we use a higher dose than 20 microgram an hour patch. Patch only. All other administration routes do not cause QT prolongation. And we don't even have higher doses available in the US. They're in Europe and Canada. So it's typically not something that you would have to worry about. But if it comes up, just kind of put that to the side. You don't have to worry. So guidance for the patch. While strict guidance asks the clinicians to reduce the total daily dose to less than 30 oral morphine equivalents before you apply the patch, this is, in a practical sense, not necessary. In fact, there's no need at all to hold the opioids for a patch dosing at any initial dose. It doesn't matter if they are at 5 all the way up to 20 micrograms an hour. The concern and the reason why they give that instruction is that they worry that there might be symptoms of withdrawal due to that buprenorphine initiation. This really is mitigated by the fact that the patch really has an incredibly slow onset of action when you first put on the patch or whenever you increase the dose. And again, that low dosing of buprenorphine is such that it's not blocking and bumping off that full agonist opioid from the receptor. Our practice is to continue the short-acting opioids as they're currently prescribed and just put on that patch. You then give guidance to the patient that it will take about 2 to 3 days after that initial patch is placed to feel that full effect or to start feeling the effect. And the full effect might not be apparent until day 5 to 7. As they feel that the patch starts to become effective after about 2 days, they should start to space out their short acting and hopefully will reduce use substantially within that first 1 or 2 patch cycles. You can increase the dose after the first patch is completed, usually about 7 days. You can go a little bit faster if you need to. I typically don't increase dose any faster than every 5 days at most. The ultimate goal is that the patch carries the most of the brunt of the pain management burden. But for some people, they might need occasional breakthrough short-acting opioids. And at this dose, you would be able to use that. So a few patch pro tips. If irritation develops, I often use intranasal steroids and I spray it to the area prior to applying the patch. You spray it on, you let it dry completely, you don't wipe it off. It leaves less residue than like a topical steroid, and therefore it has less interference with the patch when you put it on. It doesn't lead to like patch maladherence or anything like that, and it can really be effective in reducing that local irritation for some patients. I use this for, now that I've known about this, for any transdermal medications that cause problems with sticking or problems with dermatitis. You can also cut this patch in half or even quarters if the patients are wary of applying a whole patch to start off with. For my really tiny patients, my elderly patients, I will often do this to start off with. So start with a half dose and then the next week maybe put on a full patch. And particularly if they are already completely opioid naive and barely on any opioids to start off with. These are 7-day patches. They come in a box of 4. So the refills are going to be every 28 days and not 30. So case number 1 completion. So we started the buprenorphine patch at 5 micrograms an hour. We did continue the Norco 3 times a day as needed for the first week. And eventually we did have to increase her up to 15 micrograms an hour. And she has now adequate pain management. And again, pain management should be focused on functional status, less so on numeric pain scores. Is she able to do the things that she was hoping to be able to do? All right, so case number 2. This is Miss AM. She is a 58-year-old young lady with a diagnosis of metastatic lung cancer, and she's currently on palliative systemic treatment, and she's had radiation as well. Her pain is located in her thoracic spine with radicular components kind of wrapping around her left chest wall. And she also has areas of pain in her low back and her pelvis, and all of this is related to her metastatic disease. She has received palliative radiation to those lesions in her thoracic and lumbar spine with some improvement, but now the pain is progressing again. And she has an adhesive allergy. The patient's preferences: she wants to avoid what she calls narcotics. She has had morphine in the distant past and she did not like how it made her feel. She wants to avoid sedating medications. She continues to work full time. She finds her job fulfilling and she really wants to continue to work and avoid any cognitive impairment. She wants to avoid addiction. She has a son with substance use disorder and she really worries about her risks, and she also really worries about bringing a controlled substance into her home where he will be. So we thought about Belbuca for her. So the first step, again, is always to calculate that patient's total daily use of opioids. For her, she was not on any opioids to start off with. Once calculated, we use that initial dosing parameter to guide our Belbuca dosing. So for her, she is opioid naive. She's not been on any chronic opioids at this point in time. And so we typically start off at 75 micrograms once a day to twice a day. So that's a little film that goes in the cheek. You rinse your mouth out, you put the film in the cheek, you let it completely dissolve, and you should not have anything to eat or drink for at least 30 minutes after it's dissolved. If somebody has 30 to 89 oral morphine equivalents in a day, you start at 150 micrograms twice daily. 90 to 160 oral morphine equivalents in a day, 300 micrograms twice a day. And over 160, you really want to start thinking about using other buprenorphine formulations. So similar to Butrans patch, with these low microgram doses of buprenorphine, I do not worry about holding or dose reducing the patient's original full agonist opioid therapy. As these may be patients because they have slightly higher oral morphine equivalent requirements, we might be looking at somebody who has a long-acting and a short-acting opioid. So what we need to do is replace that long-acting full agonist opioid therapy with a buprenorphine. And so what I typically recommend to do is that depending on the dose of that long-acting, either OxyContin, oxycodone, typically, we would either stop that long-acting therapy. We would stop the long-acting full agonist opioid therapy. You have that last dose, and that the next dose that is due 12 hours later, you're going to start your Belbuca film. For that first day or two, you're going to liberalize a little bit that short-acting full agonist therapy. So if they're on short-acting oxycodone, short-acting Norca, whatever it is, let them know that they might need a couple more doses of that in those first few days of rotation. We typically see full therapeutic strength between 2 and 4 days of starting the Belbuca films. And so then my titration timeline is usually we increase as an outpatient every 4 to 7 days, depending on your clinic availability and your ability to follow up with a patient, or for me, if I'm in the hospital, sometimes as rapidly as every 24 hours. So case number 2 continued. We started her on 75 micrograms twice a day. The dose was increased slowly, and she's now on 450 micrograms twice a day. And her pain is tolerable, but we're still dose adjusting because her pain is changing with her disease. So case number 3, the crossroads of chronic pain management and substance use disorder management. Case number 3. This is Mr. JR. He's a 65-year-old gentleman. He has a long-standing chronic pain, and I have inherited him from a colleague who has recently retired. And he has been on oxycodone 20 milligrams every 4 hours, taking 6 doses in a day. And he has not tolerated dose reduction. He's not interested in seeing a chronic pain specialist. And he also has a distant history in his 20s of opioid use disorder that was really initiated after being prescribed opioids for pain management. For risk reduction, you want to consider rotating him to buprenorphine. His total oral morphine equivalence is 180 milligrams. And you might recall that this is more oral morphine equivalents in a day than is recommended to either start the Butrans patch or the Belbuca films. And you want this transition to be a success. You want it to be well tolerated, and you worry that abstinence or dose reduction to less than 30 oral morphine equivalents in a day would really compromise the success. So you're considering doing something called microdosing using buprenorphine films like Suboxone. So what is this, microdosing? This is a method that aids rotation of buprenorphine without precipitating withdrawal and not necessitating a washout period. So when do you think about this? You think about this when somebody's total daily dose of oral morphine equivalents is over 160 in a day. And what we're doing is using 2 milligram Suboxone films to do this. So the first day, you're going to use a quarter film twice a day. So if you math that out a little bit, that's going to be 1/2 milligram of buprenorphine 2 times a day. Day number 2, you're going to bump that up to 1/2 film twice a day. That will be 1 milligram twice a day. Day number 3 is 1/2 film 3 times a day, or 1 milligram of buprenorphine 3 times a day. Day 4 and beyond, you continue to increase by 1/2 film a day until you have adequate analgesia with, for me, a maximum dose, typically between 6 and 8. You can push 12 if you need to for pain management. You're going higher than that if you're somebody who's also comorbid substance use disorder. So case number 3 continued. We transitioned Mr. JR to buprenorphine using microdosing. He struggled initially because he missed that sensation of that pain medicine really starting to work, or kind of hit that he like realized that the pain medicine was working. And he really benefited from counseling prior to starting that transition, regarding like the differences between an IR dose of medicine and a long-acting pain medication. His pain is pretty well managed at this point on a dose of a half of a film or 1 milligram 3 times a day of buprenorphine. And right now, we have not needed to use any breakthrough full agonist opioid therapy. So, for patients with active substance use disorder or opioid use disorder specifically, currently managed on buprenorphine with new chronic or acute pain, first, if you can, get a specialist to help. Second, the recommendation is to continue the baseline buprenorphine total daily dose. So we recommend splitting from TID dosing to 4 times a day dosing, QID dosing, to really optimize pain management. The pain management benefits from buprenorphine really last about 6 hours. And so this ultimately results in, like 6 to 8 hours, I should say. This ultimately results in typically less overall full agonist OMEs that are needed for breakthrough pain management. And it adds to adequate pain relief. And most importantly, it reduces the prevalence of substance use disorder relapse. If patients have 16 milligrams a day dosing or more, which is the most likely dose if you are treating for opioid use disorder, they will likely require some very potent IR opioids to fully and adequately treat breakthrough pain in this manner. So things like Dilaudid, or in rare cases, fentanyl. So I'm thinking about somebody who had an emergent surgery that you could not come down on their buprenorphine, and they need to have some more adequate pain management. I'm thinking of somebody who's had trauma. I'm thinking of somebody who's got a new diagnosis, in my case, of things like cancer, and needs to have some better pain relief, but also still needs to maintain their treatment for substance use disorder. So some Suboxone pro tips. Suboxone is buprenorphine and naloxone. Naloxone is inert unless it's injected. There's no benefit to this other than, from my perspective, marketing. It will not block another opioid when you're using it appropriately. This is the job of the buprenorphine at high doses, not the naloxone. Suboxone tastes pretty bad. Some other brands do taste better, but if possible, depending on the dose, if you're on lower doses, if you can, use Belbuca. It's minty and it's better tolerated. You need to prep patients for this. Additionally, good dental care is really necessary because these buccal dosings and sublingual dosings can precipitate tooth decay. So we really need to make sure that patients are aware and take care of their teeth. This is that opioid equivalency chart, just for your reference, but to kind of briefly come back to it. So this is oral morphine right here. We're bringing everything back to oral morphine equivalents. So IV morphine is 3 times stronger than oral morphine. IV Dilaudid is 20 times stronger than oral morphine. Oral Dilaudid is 4 times stronger. Hydrocodone, which Norco is the same as oral morphine. Oxycodone is 1.5 times stronger. And fentanyl, this is the patch right here. So essentially, if you double the fentanyl patch dose, so if you have a 12 microgram dose, you're really giving them a 25 oral morphine equivalent throughout the whole day. This is for future reference for anybody. I wanted to point this out because bioavailability varies depending on the formulation of buprenorphine. Therefore, the different doses that are equivalent don't look equivalent when you look at the doses. So to use those 2 milligram films of buprenorphine. 1 milligram of buprenorphine film is 2 milligrams. Same thing for the generic films of buprenorphine and naloxone. The brand Zubsolv, or generic brand Zubsolv, which is the sublingual tablet that is buprenorphine and naloxone, comes as a 2.9 milligram tablet. That is, apologies here, guys. So it comes in a 2.9 milligram tablet, or it comes in a 1.4 milligram tablet. 1.4 milligrams is equivalent to a 2 milligram Suboxone film. So if you're trying to flip between these two, be aware of what these equivalencies are. If you're using the 2.9 milligram tablet, it's a half of that tablet is equivalent to a 2 milligram film. The Subutex, which is a different kind of sublingual tablet, this does not have naloxone in it. This is coming in a 2 milligram tablet. It is equivalent to the 2 milligram Suboxone film. You can come back to this, but I just want to point it out for people's awareness so that if you're flipping between different formulations of these milligram deliveries, you should know what you're using and how to switch between. So these are my references. And if anybody has any questions, I wanted to make sure that I gave plenty of time to have those questions and discussion. And I also want to give a lot of thanks to my colleagues, Dr. Smith and Dr. Irwin, as well as Dr. Kirk, who I took his slide from, and then also to my family. These are my little dudes having a good time today.
So we did have one question that came in before during registration. So we can get to that one first. So would it be better for a pregnant woman who is on pain management prescribed opioids to use buprenorphine instead for the safety of the developing fetus?
So I think it depends on nothing is straightforward with pain management, right? So if you have a person who's on occasional opioid that they're taking a couple doses in a month or a week, I don't think that there would be a significant benefit in transitioning to buprenorphine. If you have somebody who's on chronic opioids that are on multiple doses or long acting through their pregnancy every single day, there is benefit to transitioning to buprenorphine. So there's less up and down. There is less concern for, particularly for patients who are opioid use disorder, for having relapse when you have buprenorphine, for having things like abused opioids also being used at the same time. So it mitigates some of that risk. The bigger thing too, on top of all of that, is those benefits that we talked about at the beginning. So less risk to the mom and thus less risk to the baby. So that's really where that benefit comes out. Taking care of mom takes care of baby best. It still does cross the placenta barrier. It still does increase that risk for having some monitoring of children and abstinence syndrome, but it has risk reduction in comparison to full agonist opioid. And again, it really depends. Is that somebody who's all the time or somebody who is just taking a rare occasional dose?
You're muted, Katrina.
Nope, you're still muted.
I am so sorry. Any suggestions for discussing rotation to bupe for patient with chronic pain on full agonist who does not share your perspective that bupe would be safer?
I think we do our best, right? You know, I have a ton of patients who are on full agonist opioids that are long-term on this, right? That are not interested in transitioning. I think I try to figure out why they're not interested. I think a lot of the time, I mean, so just to say this, like put this out there, right? I was a nurse back in the early 2000s when we would go around with the JACO and we would get dinged if our patients didn't have zero pain and everybody got opioids. I've seen one side and I see this other side, right? And I have no desire to make a patient feel punished for something that we've done in the past that is working well for them. What I worry about is that as these patients get older and they have more risks because of multiple medical comorbidities, that this would be less risky for them in comparison to what we have on board. I do my best to talk about this, to talk about the reasons why they worry. There's a lot of worry about stigmatizing people, right? There's a lot of worry that we're not going to do the right thing for them. They're not going to be as comfortable. There's a ton of stuff there. So trying to unpack that is really, really important. But for some people, this may not make sense to them. This may not be the right choice for them. There is no ever like, you have to do this in pain medicine because it's always an individualized course that you have to take. I would like my patients to be on something that is risk reduction. But if you've been stable for many years and you're doing okay, this is a conversation we have, and it really needs to have shared decision making because, again, I want them to feel heard, and I want this to be something that works for them as well as works for me. A lot of people have a lot of different opinions about that. I feel a lot more comfortable with opioids than I think some of my colleagues do, and rightfully so. This is what I do every single day.
Okay, next question. Can you speak more on someone who is in SUD opioid or SUD outpatient treatment, specifically daily methadone? Someone who is still abusing other drugs and someone who is in recovery with no illicit use. I know it's a big, there's, I guess there's multiple parts to this question, so we can stop there and you can go for, and then we'll continue on.
So I guess I'm wondering, are you asking me about rotating from methadone to Suboxone, if that would be something to consider or not? Is that question? I'm having a hard time hearing the question in there.
Yeah. Can you speak more on someone who is in SUD outpatient treatment, specifically daily methadone? So I'm not sure if whoever put that question in wants to.
It looks like they said the person might be saying no. Could they do both?
Oh, could they do both? I don't typically recommend using two long-acting medications, so I would lean into one versus the other. I would not use two long-acting medications. Good question.
And it looks like the rest of it might be in relation to abusing other drugs and someone who is in recovery with no illicit use. So maybe like how this would work for them.
So absolutely. So, I think about this a lot in my patients who are coming in who've had a history of substance use disorder, really prioritize their sobriety, and are now with, who knows what it might be. For me, it's usually cancer, right? And you have now real pain that may not be sufficiently managed with the typical non-opioid pain management. We've tried everything. It's just not working. Across the board, whenever I'm thinking about somebody who's going to be with us for a while, months, years, whatever it's going to be, and is going to be on an opioid for a while, I always think about buprenorphine. And I also think about methadone, but that's not the conversation we're having today. So I do think about it. And I think about those reasons that we outlined at the very beginning, that risk reduction stuff, right? Less tolerance, less risk for addiction, less risk for respiratory suppression. And I go through these things, and we have to decide together. When I think about a cancer patient, I think about the fact that function is necessary to receive treatment. And if we are in so much pain that we are not able to function, then part of the treatment is pain management so that we can continue to get the treatment for the cancer, and that we will continue to help support you as you are going through your treatment. And if we are able to get you to a place that you are cancer free, then help you with backing down and getting off of these medications, or at least less pain, right? And help you get it down and off these patients. So it's really hard. And this is an ongoing conversation. And again, everybody's different, and everybody's different as far as how we approach it. But for me, when I'm working with these patients, that's the thing, right? Like, if you want to have treatment for your cancer, you have to be able to do the things. You have to get up and walk. You have to be functional. You have to do it. And if pain is limiting it, then we have to treat pain too.
And do you have any concerns with marijuana use, medical or pleasure use?
I know that people will not appreciate what I'm going to say here, but I don't, unless it's causing problems. If it's occasional use, if it is somebody who is using it maybe every day, but doesn't have evidence of either side effects or withdrawal or addiction to it, then I don't worry about it. I ask that people be truthful for me. I adhere to the UDS that we do on a regular basis, and we talk about these results. I absolutely talk a lot about using edibles over vaping and inhaling. I absolutely really discourage people who are younger using marijuana, but overall, I mean, I think not everybody, but a lot of people use marijuana, and I don't think that it's a reason for me not to use buprenorphine.
Thank you. Do you recommend any methods to identify patients with with a likely functional benefit for rotating from full agonist opioid to bupe?
Can you repeat that one more time? I apologize.
Nope. Do you recommend any methods to identify patients with likely functional benefit for rotating from full agonist opioids to bupe?
So, okay, great question. So those are the people like, across the board. If we're on full agonist opioids and we're going to be on them chronically, I'm always thinking, is this a good patient? Okay, almost always. Um, as far as functional benefit, I'm looking at number one is what they're getting adequate enough to manage their pain so that they are functional. If they're not, then I might use that as a jumping off place to rotating them to something different, to use buprenorphine. Number two, I would look at side effects. Are they having problems with constipation that have been really difficult to manage? Are they having progression of disease or new disease that's changing that might be increasing their risk for respiratory suppression? Are they, considering other medications that might be interacting with the opioids that they are on? These are things that I would say would also prompt me outside of the fact that just in general, I'm kind of thinking about it all the time. I hope that's answering what the question is asking me.
Um, Many with chronic pain on full agonists are difficult to assess for complex dependence versus OUD. Is it also difficult to assess if there is enough insight into the relationship with their medication, i.e., can they actually give informed consent to continue their full agonist? Do you have a diagnostic tools that are helpful for disentangling?
Oh, so that's a lot to unload in that question. Um, I think what is hard for me often is like the complex dependency, the tolerance, and the substance use disorder, right? This is constantly back and forth. I often will, for those patients, I use a lot of different screening tools at the beginning. I don't have a perfect one yet that I've found that helps me differentiate these things. So now the capacity question, um, I think capacity as it's defined, addiction, if they can tell me all of the things, right? Like if you go through your Applebaum criteria and they can tell you the risks, they can tell you the outcomes, they can tell you all of this stuff, they can still be addicted, but have capacity to do these things. I think this becomes falling on the provider on what medicines you're willing to prescribe or not prescribe, whether or not they can um, have the choice to rotate to something different or not. And this is where I myself struggle because I prefer shared decision making when I'm making changes. But it's much harder when you're looking at somebody, again, is this complex dependency versus tolerance? It doesn't matter sometimes as far as the benefits that buprenorphine might have over a full agonist opioid. It will have less tolerance production. It can help mitigate the complex dependency, and it certainly is a treatment for substance use disorder. So um, I guess I'm not answering your question as well as I would like to because it's really complicated and I don't have a perfect answer for you.
Okay. So I am a peer recovery coach, and I'm often working with individuals that struggled with opioids and also are in need of pain management. How can I advocate for the utilization of bupe as an alternate pain management?
So I think buprenorphine in anybody in the population, but if people have come across Suboxone for opioid use disorder, they often already start off with a predisposed worry about what this would mean for them if they tried it, right? That stigma, again, that we talked about before. So I'm gentle when I start talking about it, and I suggest that you might be too, is that, have you heard of this medicine? Here's the thing, we're learning more and more about it. We're learning more and more about how it can help patients who have pain that's functionally limiting. We tried all of these other things. I would encourage you maybe to start thinking about it if it's something you want to explore. It really depends on what kind of resources they have. Do they have a primary care doctor who is familiar with buprenorphine and might be something that they would want to consider talking to them about? Or would it benefit them to go to somebody who has a specialist level of knowledge with pain management? So going to a chronic pain specialist might be another option for them to utilize. But I think for a peer counselor, softly introducing things, starting slow and low, and understanding that like this might be a really difficult first step, but talking about it, especially if you think that this might be something that would be beneficial for them. And then having them talk to their medical professionals about whether or not it would be appropriate for them and as far as their prescribers are concerned.
That was so someone just put in the Q&A medication focused strategies.
I think it was in response to a question that I was answering. So
Oh, okay. I'm sorry.
it's okay, no problem.
Does anyone else have, those were all the questions that we had so far. Does anyone else have any other questions they'd like to ask Dr. Chargot before we end today? You can also raise your hand and we can unmute you if you'd like to ask your question out loud.
It was a great presentation though. Thank you so much. Super complex and oops, I did not mean to raise my hand. Super complex, and as always, if people do have like patient specific questions, Open continues to offer the clinician to clinician consult service on our website under programs. So if you have a patient specific question that you would like support on, you can fill out our short form, and then one of our providers will get back to you the same day. So please keep that in your mind. There.
Thank you, everybody. I really enjoyed talking with everybody. Take care.
Thank you.
Thank you.
So we will go ahead and end. Just as a reminder, if you didn't get to the CE information, we will send that out to everyone that attended. So you will get that. And with that, I hope everyone has a good rest of their afternoon.